let's quickly discuss about AKI, type 2 diabetes, and hypertension. So you see, diabetic patients are at a greater risk of requiring hospitalization, and they have risk of experiencing AKI because most of the time they even have a background CKD, and that just gets worsened because of any insult, which could be sepsis, which could be a drug that could just trigger it. Type 2 diabetes also increases the long-term mortality and morbidity of AKI. And among type 2 diabetes patient, AKI increases the risk of advanced CKD by over 3-fold, independent of the other risk factors. And this is one thing that, that keeps worsening in the patients. So it's very important that over the period of follow-ups, you keep on checking their creatinine clearance, you keep on checking their EGFR, and you keep documenting that in your prescription, because it always may not hit with the creatinine level, because sometimes if you don't calculate the EGFR, you would not know which stage of CKD the patient is on. Because sometimes these patients with a high normal creatinine around 1.4, 1.5, the moment you put it in the calculator, you see that the EGFR comes to around 35, 40, where all your calculation of the drug dosings will have to be changed. I think this is a fine line that we often miss as clinicians. That's one of the reasons for keeping this particular content in the case, is that we must be aware of checking the EGFR and documenting it. That's very important. So based on their EGFR values, their medications should be titrated, and also their insulin doses should also be adjusted. If the patient is on insulin, then you must make sure that your patient is not given extra amount of insulin, so that the patient will not have that risk of hypoglycemia. So whenever your EGFR values are going down in subsequent follow-ups, that's where you raise a red flag and you try to readjust the dose of the medications, in your prescription, so that your patient do not end up with a progression of CKD because of an acute insult. That's very, very important. In the ICU setting, blood glucose level should be maintained at a normal level. And when we talk about the blood glucose level in the ICU, it would mean try to keep it within 180. You don't want too tight control of blood glucose level. At the same time, you don't want hypoglycemia. So try to keep the blood sugar around 180, that minimizing the AKI risk without elevating mortality rates. Now, as I said, drug-induced AKI is a very, very important component, and NSAIDs are the most commonly associated drug. Remember, when you are using fluoroquinolones, this is very commonly used by general practitioners in their daily practices. Ciprofloxacin, levofloxacins are dependent on the renal function. That's very important. Moxifloxacin is not dependent on renal function. That's a very important take-home point about alone. One of the cephalosporin, cefepime, is contraindicated in patients with EGFR less than 30 due to risk of CNS toxicity. That's also an important take-home point. Aminoglycosides, vancomycin, ceftazidime, cefazolin, fluconazole, piperacillin, carbapenems, sulfamethoxazole require dose adjustments in renal impairment. Cephalosporins and penicillins have a wider therapeutic indices and vary in the need for dose adjustments. Once again, a quick highlight to all of you that whenever you're prescribing any medication, it's quickly easy to check on their EGFR and see if the drug needs any dose adjustment as per their renal function. This is even applicable to the use of, oral anti-diabetic drugs and the various molecules which we use in the treatment of diabetes. So a textbook picture, this is how to approach a case with oliguria. You try to categorize it, whether it's pre-renal, whether it's intrarenal, whether it's post-renal. If it's a pre-renal, then obviously your bun to creatinine ratio will be more than 20:1. FeNA will be less than 1%. Urine specific gravity will be more than 1.02. There'll be more presence of hyaline casts in the urine sediment, and there would not be any evidence of obstruction or intrarenal causes. What do? You just hydrate, eliminate the toxins, and you treat the causes. If you're looking at an intrarenal cause, the bun to creatinine ratio would be between 10 to 20. FeNA will be more than 1. Urine specific gravity will be between 1.01 to 1.02, and there'll be tubular or granular casts in the urine. Ultrasound may show medical kidney disease or normal, no obstruction would be there. And the other cause is, of course, the post-renal cause, which would definitely show some kind of a pressure effect, that is hydronephrosis. Serum and urine tests have similar results to the intrarenal causes. So if it's an intrarenal causes, you definitely try to rule out the particular cause, you treat the cause, you eliminate the toxins. And very important is that whenever you are suspecting an intrarenal cause, you must refer to a nephrologist. That's very, very important. Pre-renal, you can correct it, and pre-renal azotemia will be corrected, and that gets completely reversed. But if you're suspecting an intrarenal cause, it's very important you bring the nephrologist into the picture. And again, when you look at the post-renal cause, you're looking at an obstruction. You need to bring in a urology. You need to order a CT and see if that obstruction is evident or not, and treat the patient accordingly. So renal components does exist in patients with metabolic problems, and this is something that as physicians, as clinicians, we must look at. So how do you manage this case? An IV fluid resuscitation to maintain adequate renal perfusion. So it's again that fluid balance, very important. You correct the electrolyte imbalance. You use diuretics to correct the volume overload. At the same time, you don't make the patient get dehydrated. So that is very, very important. That balance is important. Discontinuing all the nephrotoxic drugs. Keep a steady glycemic control. Target CBG less than 180. If the patient needs other supportive measures like ventilation, anemia management, etc., you give them. And of course, renal replacement therapy will be required in such cases if there is a refractory hyperkalemia. That's very important. Unresponsive volume overload, if there is a uremic pericarditis, pleuritis, or encephalopathy happening, or if there is an intractable acidosis, or in cases of acute poisoning, those would be the indications of putting a patient on renal replacement therapy in the setting of AKI. Let's go back to the case and try to understand how the patient was about a few months ago. So let's look at the past visit. This patient had an outpatient clinic visit 6 months ago with complaints of lethargy, pain, swelling, tingling, and numbness in the feet, nausea, and vomiting going on for a month. And at that point of time, the patient was still overweight. BP was on the high side, 170/90. The respiratory rate was 18, saturation was normal, temperature was normal. He was not in any acute distress, but the patient was definitely having elevated blood pressure, weak palpable peripheral pulses, and had diminished pen sensation along with tingling and numbness in the both lower lips. So definitely you can see the patient was going into a state where the patient was definitely having neuropathy with probable evidence of peripheral artery disease, and the patient was also having erratic differences in his blood pressure. And you remember from the history, your patient is a smoker. That is also very important. In the past visit, the patient had absolutely normal, cardiovascular examination, normal breath sounds, nothing per abdomen, CNS examination was normal. And in the fundoscopy, the patient was having evidences of diabetic retinopathy. Remember this again, a very take-home point is in a patient who would have some category of nephropathy, they would definitely have a coexisting retinopathy. So that's also very important. So if you have a patient with microalbuminuria, worsening kidney function, rising creatinine trend, do not forget to check the patient for retinopathy, because the patient would definitely have a coexisting retinopathy, which would also be fast progressing. So that's a very important take home from this case. How was the blood parameters in the past visit? Remember, I kept referring to the fact that you need to see the previous creatinine. What was the previous creatinine level? So this is how your patient was 6 months back. Fasting 186, PP 249, A1C 8.8. So sugar was not under control despite of being on insulin. And his baseline creatinine 6 months back was 1.5. So yes, your patient does have a degree of renal parenchymal disease, maybe an early stage. This would be a stage 1 or a stage 2 CKD. If you calculate the EGFR, so the EGFR, had been calculated to be around 24. So that's quite actually bad. And also the patient had a proteinuria of 1+. So that was 6 months back. And at that point of time, the patient had some degree of CKD. But what caused this AKI was not the CKD, but the acute insult of some inadvertent use of drugs, especially in this case, NSAID, which actually aggravated the CKD into a stage of AKI. What was the other findings? You see the Doppler of the lower limbs had mild stenosis with bilateral femoral artery. So definite evidence of peripheral artery disease. And 10-gram monofilament testing was done of both the feet. There was loss of protective sensation and increased risk of ulceration. So that is very, very important. So you definitely have signs of neuropathy as well as peripheral artery disease. going on for the last 6 months in this patient. So this is your diagnosis. You have a patient with hypertension, diabetes, kidney disease, as well as diabetic neuropathy, which is now presented with AKI and heart failure with preserved ejection fraction with a bad foot ulcer. Now, this patient was, as I said earlier, was being managed with atenolol and enalapril for the management of hypertension. He was on metformin, 1000 milligram twice a day, and human insulin. Now, this is again why we keep pushing on this point is, would you really be comfortable going ahead with this 1000 milligram twice daily metformin with this CEGFR? No, you needed to adjust that, which was not done. So that is the titration that needs to be done. So see, there are a lot of triggers. If you don't adjust the drugs on the right time, your patient will present with acute kidney injury, or your patient will present with a complication because of the drugs. So these are the pitfalls of clinical medicine that needs to be picked up. Patient was on pregabalin. Patient was educated on proper foot care to be followed to avoid foot ulcers, and the patient was advised to follow up with the GP with 3 to 6 months as a follow-up.